Hi, I'm Joe Fifer, President and CEO of HFMA. Welcome back to our web video series. This month I'm talking about a short-term versus a long-term perspective and why that should matter to finance leaders. Neither one. I'm actually referring to the overall financial strategy that's best for provider organizations in the short term, that is in a fee-for-service environment, versus in the long term when value-based payment becomes more predominant. Most finance leaders are familiar with the conflicts between the two payment models, but even though they get it, some are holding on to fee-for-service as long as they can. That's understandable, and it may even be the right thing to do from a short-term earnings perspective. Exactly. In the long term, a quarterly earnings mentality is not going to cut it. I realize that the transition to value-based payment has been slow and uneven, but innovations in care and payment models are likely to change that. The pace of change is accelerating. Providers that turned a blind eye to the innovations in this field risk being caught flat-footed when fee-for-service starts dropping off. At HFMA, we've been talking about this for years. Nobody can say they weren't warned. There are tough decisions ahead, that's true. But let's keep in mind what value-based payment is all about. It's intended to drive what's best for patients. In other words, health care that truly improves people's health and their lives, rather than just delivering services. Consider chronic conditions, which account for the majority of healthcare expenditures in this country. As we develop new care models that can better prevent complications of chronic conditions, rather than just treating them after the fact, as we often wind up doing now, will that improve people's lives? Absolutely. It will also lead to excess capacity in the acute care sector. Is that a reason to resist the new care models? Some people would defend that choice. One thing you can be sure of, resistance is not a long-term strategy. And those who continue resisting are going to wind up on the wrong side of healthcare history. Traditionally, reducing capacity means closing hospitals or cutting bed count significantly, and those are not easy prospects to consider. But there's a third way. Rather than close hospitals, redefine what it means to be a hospital. With today's technology, a hospital without beds can still be a hospital. For example, Mercy Hospital launched a virtual care center in the St. Louis area in 2015. It's a 4-story hospital that houses a variety of telemedicine programs and 0 beds. As Mercy puts it, patients no longer have to physically seek out care or entirely reorient their lives to gain access to specialists. Virtual technology brings care to them. Or, if not 0 beds, a hospital could have fewer beds without framing it as a loss or a failure. Plenty of services can be provided in a downsized inpatient environment. In that scenario, providers need to collaborate to deliver the care their community needs more effectively and efficiently without fragmentation, gaps, duplication, or waste. That means we'll probably see a continuing shift toward larger, better-run provider organizations with better alignment of incentives between the health plan and provider communities. The takeaway message is that choosing short-term gain over improving value for care purchasers will come back to haunt us. It will eventually lead to a loss of autonomy for physicians, hospitals, and others on the front lines of care who know their patients and communities best. That's not a scenario any of us want. The choice between a short-term and long-term outlook is yours to make. Choose wisely. Thanks for watching. I'll see you next month.